Thank you, Representative Kelly. You know, I find it interesting on some of our documents. I've been in medicine now for 35 years, and I'm looking at some of the documents here, and I know this is absolute Greek to my fellow colleagues who don't know what this is, what a SNF is, what a long-term care facility. And truth be told, it's a little Greek to me, because whenever I'm in a hospital, and in my field, urology, we do mostly outpatient stuff, but we still sometimes do long-term. If we have to do cancer therapy, somebody needs long-term care, or we consult on somebody that needs long-term care. And then if you look at the tyranny of what our government has done in the rule after rule after law after law, no wonder the medical system in the United States is screwed up. No wonder it is. Because if you have so many different regulations, when I was chief of staff of our medical center, 1,000-bed level 1 trauma center, we had, during my 3-year tenure, 3 different rules about how an outpatient person would be categorized. Whether they're overnight, whether they have to stay 2 nights in a hospital, whether they can go to a SNF, or you literally have to keep them in a hospital an extra 2 days just so that they'll qualify for some of these things. And this is where I am beyond ecstatic that we have a president and a government that is actually willing to step back and look at this nonsense. Because frankly, before I came to Congress, once I got here, I said I would go down to CMS, which, by the way, nobody's been in the parking lot for the last 4 years, that I'd go down and fire 1/3 of the people, because it is rule after rule after rule created so that they have something to enforce. And I say this not only on the hospital side, but I also say it on the physician side. In our practice, we have grown and grown and grown individuals to try to put laws or to try to enforce regulations that were put forth by the government. You look at all of these things. There's no stability in this whatsoever. And if you look at the number of folks who are now employed by the hospital that are administrators, and you compare the growth of them versus the growth of actually the people who take care of this, why does this delta occur? It is because of CMS, it is because of government. And Mr. Carlson, I'll go back. You know, you talked about the nursing home mandate. There's so many disqualifiers. If we could find the nurses in any corner of the country, we'd be happy to do this. But we have beds at our institution that are closed, that are desperately needing to be opened, because we have folks sitting in our emergency room for 36 hours waiting for beds because we don't have nurses. It's fine, I'd want that higher level of care, but we literally, number one, can't find them, and 2, can't afford them. I'll go back to some of the other remarks that were made. You know, in North Carolina, from April to September of last year, at least 360 patients were medically cleared for discharge, but did not have appropriate post-acute care placement. So what happens? They sit in the hospital, and what happens? Not only do they get nosocomial infections, they get infections from other people. Ding, 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 it rings up the bill. Ms. Grabert, I have a question for you in a second. You know, look, I think Medicare Advantage is making a steal on everything here. I'll agree with Mr. Blodgett on the other side of the dais here. Medicare Advantage will start with a great intention, but is absolutely determined that they're going to steal the taxpayer dollar hand over fist. And United Healthcare is the #1 offender from what's happening from my vantage point, and I think a lot of the federal agencies also. The average wait time for the patients that I talked about, Mr. Chairman? Can I continue? Okay. Average wait time for the patients was 73 days. 73 days for these 360 people. 51% of the patients waited over a month, 25% waited 3 months to 2 years. Guys, I love the concept of home health, because I think that's where care is done best, if at all possible. Ms. Grabert, I was astounded by the numbers that you gave about the profit margins of some of those. And I look at the problems here. We're trying to actually get the physicians to not get cut more and more from pay that have happened over the last 20 years. 62% of Medicare beneficiaries were waiting for a skilled nursing facility placement. 44% had serious mental or substance use disorder. So the system is broken. For all those crying out that we can't do this to Medicaid, we can't do this system is broken. 1 to 3 years, we're going to have a financial insolvency of our country. Medicaid desperately needs to be reformed. All the cuts and all the scare tactics from the other side of the aisle, patients are still going to be cared for. But if the Biden administration finally would let us audit the Medicaid rolls, which they didn't do for 4 years, we would get people off the Medicaid rolls that don't deserve eligibility. Our psychiatric hospitals in North Carolina had the longest wait times whatsoever, 197 excess days. So we have a problem with getting people from the hospital to the care that they need. For every 3 Medicare beneficiaries waiting in a hospital, 2 out of the 3 are involved in a Medicare Advantage plan. The largest 3 MA plans denied prior authorization requests for post-acute care level at higher levels than did any other types of care. So yeah, maybe our fee-for-service Medicare needs to be fixed, but good Lord, our Medicare Advantage plan needs the wrath of God to come down and fix that system. Ms. Graybert, in your view, let me ask you this. If you're a hospital administrator, if you're a physician, if you're a nurse administrator, what do we do to streamline both discharges and prior authorization requirements? Because there's an entire cottage industry that we have to alert our nurse managers when we think that patient's going to be able to leave. I mean, heck, as soon as I put scalpel down, it's like, when is the patient leaving? So tell me how we streamline that process.
Thank you so much for the question. One of the things that you mentioned, I believe you referenced the 3-day stay requirement in an inpatient facility that's required before Medicare coverage into a skilled nursing facility. I think this is a perfect example of something that is in statute that is really causing some of these issues on an inpatient basis. So I totally share your concern regarding this specific rule. To repeal that rule could be very cost prohibitive. So what you need to take...
What do you mean? Can you explain that?
The reason the rule is in place is because it prevents switching of benefits between Medicare and Medicaid. And so to control fee-for-service utilization, that rule is in place to push down utilization.
So we keep people in the hospital longer?
Yes.
So they're at more risk for DVT, nosocomial infections, et cetera, et cetera.
That is the unintended consequence of the policy.
Yeah, and that costs more money because it makes people sicker, and guess what? They stay in the hospital.
Yes, and your point is well taken. The way that the Congressional Budget Office, unfortunately, looks at that, they're only
All right, don't even say CBO around here because I don't believe anything they say. Sorry about that.
The way that they sort of consider that, they probably would assign a pretty cost-prohibitive score to repeal that rule. Because that is their perspective on that particular policy, you may want to also consider the revenue to go along with that to offset it. And that's why I describe things like the 3-day stay as regulatory relief. You could possibly generate the revenue from a unified PAC PPS.
Right, but that's when people are given DRGs, they're paid for this diagnosis, they're staying in the hospital. It could be 3 days, it could be 300 days. The hospital still gets stuck with that bill. So how do we cut down the regulation? How do we cut down the burdensome administrative paperwork? We take an axe to it. And this is where CMS, again, this is what this government has done. And this is Republican and Democrat problem. This is what's happened in every agency. And this is why I'm so glad we're finally having a reset of our government, is to look back and say, this is ridiculous, because it's add upon, add upon, add upon, add upon. And things just don't make sense for patients or the people who care for them anymore. I'm glad, I appreciate everybody's remarks today. I hope we get to the point where we're not just making remarks, but we're actually fixing what is a badly, badly broken American medical system. Thank you, Mr. Chairman. I'll yield back.